So today my role is to propose a framework for how to bring climate change and basically how to bring climate change to clinical medicine through the avenue of graduate medical education. And so what I'm going to be hoping to do is to discuss why it is so imperative that clinicians be trained in climate change medicine and to propose a fellowship curriculum and discuss outcomes and benefits of such a training program. So when it comes to the topic of climate change, my experience has been that physicians and other healthcare providers have been relatively silent on the issue. There's currently no climate change education in medical schools, there's no climate education in residency programs, and very few clinical societies support the notion that climate change is occurring. In general, it's not something we talk about in hospitals and clinics and emergency rooms. We don't talk about it with patients, and basically it just doesn't really exist in general. However, recently, The Lancet argued that there is no group better poised than healthcare professionals to spell out the importance of acting on climate change. They point out that the healthcare sector has the clinical evidence, has the ability to shift the lens through which climate change is viewed, and has the public's trust and perhaps even the responsibility to take action. So as these authors in The Lancet point out, tackling climate change could be the greatest global health opportunity of the 21st century. And moreover, healthcare professionals are tuned in general, we're pretty excited about these ideas. So this was a survey of NMA physicians that showed that 97% believed that climate change is happening, 88% believe that climate change causes harm in their communities, 80% agree that climate change affects their patients' health, and most have even come to the conclusion that there are these vulnerable populations that are going to be disproportionately affected. So why is there such a conspicuous absence of climate change in the healthcare community when this great opportunity exists and we know it's so important? So I would hazard a guess that it comes down to our training, to residency. So residency is a bit like living under a rock. We don't appreciate that climate is changing because we rarely leave a climate-controlled environment. And I'm not kidding. So skills we gain are in clinical medicine, are in patient communication, and some limited exposure to clinical research. But despite this great clinical training, we have very little interaction and influence in conversations outside the hospital. And we interact only very rarely with the fields of public health, of policy, of environmental medicine, and of occupational health. So meanwhile, time passes, the world changes, we spend 10 years in training, and we graduate residency with great clinical skills, but with no connections and no basis for having any meaningful conversations regarding the root causes of illness and social distress we've come so intimately to know. We've no seat at the table where conversations are had related to climate and health. And honestly, I think this comes from the fact that we don't really know enough about it. We don't know enough about climate change. We're not climatologists. And so we don't feel like experts, and we don't feel empowered to really bring anything to the table. But I would argue that in one aspect, we are experts on the health effects of climate change, and that's because we see it every single day. And the view from the emergency room is that we take care of patients who come in with exacerbations of chronic climate-sensitive illnesses such as asthma, COPD, CKD, and cardiovascular disease. We see weather-related and intentional injuries associated with violent crime, which in turn have been shown to be associated with climate variability. So just as an example, on average, EDs across the country see approximately 30 million non-fatal injuries every year, and these numbers are expected to increase. Through deteriorating water quality and food quality, we see increased outbreaks of waterborne and foodborne illness. The estimated incidence is approximately 210 million cases, I read in one place, annually, resulting in almost 1 million hospitalizations and 6,000 deaths. Additionally, novel climate-sensitive infectious diseases present to the ED, for example, West Nile, dengue, Hanta, Zika. And interestingly, in both Aurora and Denver, there are large international populations who live there, from North Africa, from Nepal, from South America, who are maybe perhaps in and of themselves climate refugees, who come to the emergency department with their endemic infectious diseases and use emergency departments as their primary access to health care. And lastly, EDs function as safety nets for vulnerable populations. And these populations, such as the elderly, homeless, and mentally ill, who are often the first to declare themselves during climate-related events. So as a result of this, there's been some interesting research related to climate and health that has emerged from the emergency medicine literature, ranging from observations of increased ED usage with extreme heat, the effects of flooding on ED usage, and projections of cost and ED strain in future climate scenarios. So the bottom line is that the healthcare profession is already involved with climate change and health because our patients are affected by climate change. And from what I can tell, the net effect is going to be more patients, it's going to be more severe illness, it's going to be more complex novel diseases. And on some level, we're choosing to not acknowledge it because we're choosing not to talk about it, which means that as a system, we're not prepared for what is going to happen in the future. So just a quick anecdote. Whenever the emergency department gets really busy with sick patients and outbreaks of violence and gunshot wounds, and it's crazy, people tend to think it may be related to some kind of astrologic event, such as the full moon. You know, it's crazy, there's a full moon. So I sense that people sort of feel like there's some larger phenomena occurring that is influencing human health. But I would argue that it's not the moon, but it's the climate. And I think we have the opportunity at this point to transform these ancient superstitions into evidence-based knowledge about how and why climate impacts human health, and to bring that knowledge to the medical community, the policy community, and to the people who really need it most. So I'm going to change gears at this point and talk about a framework for a post-residency, postgraduate training for clinicians in the field of climate change, because it currently is not something that exists. There's nowhere you can go after residency to get trained in climate medicine or any avenue to get into this field. So what's the best way to equip young physicians to affect large-scale change? And I think that the bird's eye view of this is that it comes down to policy training, to clinical climate health research, to developing leadership and education, and then spending time with boots on the ground, working in national and international disaster settings. So ultimately, what we're doing is we're creating a, oh wow, that's crazy font. What's that supposed to say is climate medicine, and that's, maybe it got translated to Russian or something? Awesome, cool, I like that better. So ultimately what we're doing is we're creating a new subspecialty of medicine, and it's called climate medicine, clearly, which is dedicated to understanding the ways in which climate and environments impact human health. So you can go after residency and you can get trained in toxicology, you can get trained in nephrology, and we want it to be so you can get trained in climate medicine, that it's actually a real thing that exists. So what training do you need to be a climate medicine physician? So I'm just going to run through a syllabus that Dr. Lemery and I and several others have been working on to try to outline exactly what this means. So because you're taking clinicians that have literally been under rocks for the past 10 years, they need some additional basic scientific training. So starting with understanding the origins of climate change, sources of greenhouse gases, and a basic understanding of climate modeling. They need to have a familiarity with current climate change projections, both in the US and globally. They need a basic understanding of epidemiologic research methods and occupational exposure medicine. And they need to have a familiarity with relevant policies outside of health, for example, urban planning, education, and other arenas that could be health relevant. They also need a basic understanding of methods and principles of policy analysis, and a foundational understanding of the US government and relevant state policies and institutions. So this education will come through partnerships with the CDC and the NIH, and specifically the fellow through the university program will work through the CDC Climate and Health Program and the NIH's US Global Change Research Program, where they'll receive close mentorship and work on a variety of contemporary projects. Climate change physicians also need knowledge concerning international institutions relevant to climate change. Thanks. And health, such as the IPCC, the United Nations Framework Convention on Climate Change, the World Health Organization, the World Bank, and more. Climate change physicians also need a deep understanding of the physiologic, ecologic, and social interactions and exposure pathways resulting in the health impacts of climate change. And the idea is that this education is going to come from working within the consortium, whereby the fellow partners with and assists faculty with current initiatives, because the truth is that everyone in this room and the faculty in the consortium are the vanguards of this field, and they are the ones on the cutting edge, and this is where clinical folks like myself need mentorship and training. The climate physician also needs training in performing and evaluating vulnerability assessments and working with tools such as the CDC's BRACE framework and others. They also need the ability to conduct literature review on specific topics in climate change and health and to apply those to given community scenarios. Lastly, they need skills in acting as a communicator between various disciplines of medicine and science and between the academic realm and important stakeholders such as policymakers, U.S. medical societies, nonprofits, and larger media organizations. And additionally, strong leadership education, so to bring all this information and knowledge into the realm of K2 education, of clinical education, medical school curriculum, residency curriculum, and basically wherever we can get this information out. So we've been talking a lot this week about threat multipliers. So I'm going to steal this concept and make the analogy that what this fellowship is a force multiplier for our local consortium and for the larger national, international climate initiative. And I think what it comes down to is connectivity. Through partnerships within the clinical community and the CDC and the NIH, our local consortium is strengthened. Through forming interdisciplinary bridges into clinical medicine, everyone's work gets closer to the communities and to the patients who need it the most. So on a large scale, just to conclude, we're creating a subspecialty of clinical medicine that serves to foster greater interdisciplinary action towards easing and buffering the effects of climate change on vulnerable populations. It inherently leverages the power of clinical medicine, leading to greater health advocacy. It serves to increase education among health-related professions. It furthers climate health research, and ultimately it leads to wider health system preparedness and response domestically and internationally. So one reflection I've had from our sessions this week is that I think we need more connectivity among our local consortium. And I think that potentially this fellowship, as it continues on through the years, could help to foster this because the fellows serve in this position where they're getting education from basic scientists, from clinical folks, and that they can kind of bring together group projects that draw from all our various areas of expertise to produce sort of meaningful outcomes. And so the idea is that there's anchor projects that exist in our consortium that everybody kind of contributes to and everybody draws from. And the fellow kind of sits somewhere in the midst of it all, trying to absorb information and also make action. So at this point, I'm going to turn it over. I look forward to the future and to all the great ideas to come. So thanks for your time. I think Jay was going to say a few things about this.
We have a few minutes for discussion, so if anyone has questions, we'd be happy to entertain them. Yeah, hi Lee.
Cecilia, I want to comment on the training aspect of this because I think it's so pivotal, and I know we're going to come back to it. And I think what you said just really resonated for me. I came out of the world of medicine, right? So I was a professor of medicine before I was a professor of public health. And I realized that these are two areas that know different things, and you don't even know what the other knows and brings. And I've learned more the last few days about the world of our colleagues who are in climate and climate education. And I do think that there is an opportunity here for us to conceptualize this actually even more broadly than what you described. So maybe the point for discussion today, or like now or later, is where are the points where we can kind of get another multiplier by having overlapping training or shared training for people coming from public health, from climate, and from medicine. And maybe you have some thoughts about that.
No, I think that's a great point. Go ahead.
Thanks. That was a great talk. I just wanted to chip in also. We, myself and others, were part of setting up the Global Health Institute through SUNY, which is 64 universities. And one of the topics we talked about a lot was creating sort of gold standard research and training platforms overseas. So that's one of the ideas I would put to this group also is, we have sites that we've been working in for a long time. We have known partnerships, infrastructure, we're doing climate and health work. How can we bring that to this consortium? And sort of create this trusted space in this community where we can provide those opportunities for training to work with the local community's service and to develop these long-term climate and health research and training platforms, such as a lot of the places where you guys are already working all around the world. How can we formalize that through the consortium as well?
Right, like is there an avenue for medical students and for residents to come down and get training in climate medicine? Yeah,
Just,
go ahead.
just one second, I just want to comment. So, thanks. First of all, I just wanted to shout out Lee. Where'd you go? Oh, sorry.
Lee's a climate physician.
Lee was very instrumental in helping us sort of articulate when it was a proto version of this. So thank you, Lee, for your mentorship. And again, this is meant to be something that once we actually get it even green lit, which is, I think it's probably between yellow and green at this point, that will bring it back to the consortium, because I think there's so much, horsepower in this room that we can all benefit from that. So I just wanted to say that. So Jason, sorry.
Oh, that's fine. Just to overlap with degree seems kind of obvious, right? You could get clinicians in there looking through registries with other clinicians in other countries that are affected by things like chronic kidney disease, and you can look at some of the prevalent studies right in the clinic, and the ones that want to get more community medicine training, boom, you go do a community cohort, or a community prevalence study. So I mean, degree is not owned by London School. It's quite the opposite. We want to get it out there. So that'd be a very nice overlap and easy overlap in some ways.
Yeah.
That's a great idea.
Yes, Renee.
I have a question. In your experience talking to other residents about this, because I'm sure you must have shared this with your fellow residents, does it resonate with the residents that you've talked to?
I think they're just like, wow, really? Like, what? No, I think they're just kind of shocked, and you kind of tell them a little bit about it, and then there's a lot of like hand waving that happens. But you know what I mean? I think that people are really excited. They're like, I think that mostly they're actually like, I didn't know you could do that. And it's kind of like, well, shoot, if I knew I could do that, maybe I would have done that. So I think that I think people are interested, and they just don't know how.
I can speak to that. The answer is yes. People look at this and they're wide-eyed, and I think this fellowship is interesting because there's some fellowships that are actually very well codified. I'll just speak for emergency medicine, pediatrics, toxicology. Those have boards and exams, and there are other ones that are just frankly just crap. But this one is one that I think resonates because it's new, it's innovative, and it's obviously not ACGME approved. We don't want that right now, but it's substantive, and I think people see it, they're excited, and they realize like, wow, after that, my horizons will greatly open up. And so I know 3 people who are maybe coming after you that are like, keep me in the loop, I'm really interested. So answer is anecdotally, yes, lots of it. So George, comment.
So I think there's an expanded role in this capacity, not just maybe a dual role. One, to certainly speak to the physician community, expand the knowledge base, which desperately needs. But also to engage with the adaptation planners who are looking at things like critical infrastructure vulnerabilities, how those intersect with other trends and vulnerabilities, and you're really, occupy a place on the front line to not only bring those vulnerabilities to light, but also to direct policy. And then that, in turn, is so important because we as federal agencies have very little capacity to direct local policy. It could be local, it could be statewide, et cetera. And so there's a real heavy burden maybe on this very nodal position that I think can benefit from it.
We'll do Jonathan, then Lily.
So that was almost exactly what I was going to say, and I'll just sort of elaborate a little more that, yes, of course, we all embrace the fact that our health depends on far more than the health sector. And so, working across clinical specialties, that's one thing, but emergency medicine is on the front line with the built environment, with our environment, and so to be proactive and get into, meeting with urban planners, with construction people, and all, this is where ER especially may have a unique role to go outside the health sector and go, to the upstream determinants of some of these things. So exactly the question.
I second what he said.
Yeah.
You guys hang out too much.
Just one thing is, we in emergency medicine, as I've had to articulate this to my peers, I say 2 things. I said, we should own this within the House of Medicine, clinical medicine, because we are the vulnerability physicians and we are the disaster response experts. When you frame it like that, at least again to a very specific EM community, I think eyebrows raised. I'll just say the American College of Emergency Physicians and the whole EM community right now is we are way behind even our peers in medicine or peds. They just don't get it. So there's a lot of work to be done. Billy, and let's make this the last comment.
So this is such a cool framework, and you kind of just touched on my question, which is, there's so much opportunity with such an interdisciplinary training like this. Where do you envision people specializing in this landing and having such a unique skill set, what would be the feeder program for that?
What are you gonna do?
Go ahead.
Where are you going?
I don't know. I don't know. Wherever I could be useful, you know, and being a connector. I think that's the real thing is you learn how to speak the language of everything, of occupational medicine, of government, and then you're able to sort of get in and sit down and talk to people with actually really know what you're talking about. And that kind of power, I think, could take you anywhere. That there needs to be advocacy. I mean, really, I think where you're becoming as an advocate from a really strong, very scientifically grounded background.
We'll have to hold questions because I think we need to move on to Steve, and then we'll